problem, sir. No problem.
Because I have.
Our audience is a pediatrician. They need only Cripsil.
But one thing is sure, you will not get bored.
Sir, we are right.
I have kept only the
So
cases.
good morning. Dr. Dinesh, please start. Dr. Dinesh, you are on mute.
एमसीडी की कूड़े वाली गाड़ी आ जाती है ना तो वो बहुत
Dr. Dinesh, we are live. Please start.
Yes, sir. Yes, sir. Very good morning to all of you and very warm welcome on the behalf of IIP Delhi. And
So shall we start?
Yes, sir.
We just introduce and then start, sir.
Yes, just 1 minute, sir.
Okay.
So very good morning to all of you and very warm welcome on the behalf of IIP Delhi, sir. And today's session in on upper GI bleed is very, very important. And we have an eminent speaker, Dr. VIKAS from PJMR Noida. And I welcome you all in this very important session. Welcome all delegates also. And now over to Dr. Ajay, sir.
Thank you, Dr. Dinesh. On behalf of IIP Delhi, I welcome all the respected faculty and the delegates. I also welcome expert for the day, Dr. Rimjam Srivastava. She is a prominent gastroenterologist at Raipur. And I'm really thankful to Dr. Shamina, who is coordinating all these sessions. And hope all the delegates are learning something new in all these sessions. And it will be useful in their day-to-day practice also. Over to Dr. Shamina.
Hello, good morning to all our Lord delegates, our speaker, chairpersons, office bearer of IIP Delhi. First of all, I would like to thanks to team IIP Delhi under the leadership of our secretary, Dr. Dinesh Goyal, our president, Dr. Ajay sir, and all the office bearer staffs and our background workers, including Sushilji and Anilji. Definitely, I got the opportunity to highlight our experts along with important topics related to child health, including gastrointestinal issues. Today's we have the GI bleeding talk that the today's talk going to delivered by our eminent speaker Dr. VIKAS Jain. Dr. VIKAS Jain is qualified gastroenterologist. He did the after MD to DM from the SGPGI Chandigarh. After that, he did the currently working in the Postgraduate Institute of Childhood Noida as an additional professor. Dr. Vikas has a lot of the publications. He's contributed to the various chapters related to gastrointestinal disorders. And Dr. Vikas also had the various award like the one of the prestigious award is ESPEGAN, European Society Pediatric Gastroenterology, Hepatology, Nutrition Young Investigator Award in 2015. He had the numerous publications and international papers. So definitely today's talk is delivered by the Vikas is very worth and useful. And for the intermittent valuable inputs and chairing the session by the Dr. Rimjim Srivastava. Ma'am, currently working in the Ekta Institute in Raipur. Dr. Rimjim?
Yes, sir. Yeah. I'm at place at Raipur.
Ma'am have the also have the vast experience in the GI field. She earlier have the numerous publications, chapters in the book. Also have the lot of the CME and workshop conducted by the him. And last we meet in the last 2024 Pedicon. He did the wonderful job in on same topic on GI bleeding. So after that we decided we'll do the other activities related to same thing. So today's we have the opportunity to for on same topic. So thanks for accepting the invitation, ma'am. Now without wasting the time, we are going to start our talk. Before that, I hand over to our president for the any further. Dr. Ajay. Chalo. Over to Dr. Vikas.
Good morning and thank you, Dr. Sham, for introduction. And first, I would like to thank and show my gratitude to IIP Delhi and especially President IAP Delhi Dr. Ajay Kumar Gupta, Secretary IAP Delhi Dr. Dinesh Kumar Goyal, and last but not the least Dr. Shyam Sundar Meena, who keep me enrolled in different IAP programs. And really, Dr. Shyam is a very dynamic person, and such this I usually remain in touch with him. So thanks, Dr. Sham. And lastly, with due permission from chairperson, I would like to start the presentation. Dr. Rinjim, shall I start?
Yeah, sure, definitely.
Okay. So today topic, this is a session 5 of eGastro module, and topic is approach to the gastrointestinal bleed. And this topic is little bit vast. I try to just split this topic in a two part. One is a upper GI bleed and our second part is a lower GI bleed. So I would like to cover the presentation in the two parts. First, I will cover the upper GI bleed, and then in the second half, I will cover the lower GI bleed. So first and most important is what are the type of the GI bleed and what are the different terminology we use in while managing the patient of the GI bleed. So as you all know, hematemesis is a very well known with the blood in a vomitus, which is a indicative of the blood in a proximal gut. Proximal gut means proximal to the ligament of trees. So it can be the bright red and it can be the coffee ground if there is some blood spent some time in upper GI tract and can come in contact with the acid. So it can be the bright red or coffee ground. Second is a melena. Melena is basically originating when the bleeding is originating from the upper GI tract and it is passing from the lower GI tract and the blood has spent some time in GI tract. So basically it is an indicator of the proximal small bowel. Last is a hematochezia. So bright red color of blood per rectum indicative of distal bowel, but sometimes because in the massive upper GI bleed, hematochezia can be the presentations. And somewhat in between the hematemesis, melena and hematochezia, there is a maroon color blood. That is an indicator of a middle bowel, means the jejunum and the ileum. So upper hematemesis and melena, then maroon color, and then lower down hematochezia. So as I've already discussed, upper GI bleed proximal to the ligament of trees is hematochezia, melena, rarely hematochezia if the bleed is massive. And lower GI bleed, either we will get a maroon color blood, melena, or hematochezia. So these three, melena, maroon, and hematochezia, and from the lower GI bleed is indicated of different level of the bowel involvement. So another thing is a different terms in terms of the whether the blood is visible or not. If the blood is visible from the GI tract, then we label this is the overt GI bleed. In our presentation, we basically discuss the reason of the overt GI bleed. Occult GI bleed when the blood is invisible, and we just come to know about the blood loss from the only by the some test that blood is lost from the GI tract, but there is no visible blood. Last is the obscure GI blood. This term usually used when there's a bleeding from a site that is not apparent after routine endoscopy in terms of upper GI colonoscopy and sometime in the small bowel dilation. So we label this entities as obscure GI blood. Like one example is a dulophoid lesions. Dulophoid lesion is a lesion whenever in the upper GI tract there's a massive blood hematemesis vomiting, but when we do the endoscopy, we usually could not find any lesion in the upper GI tract, and this is basically a free artery in the submucosal space, and through which the blood loss occur. So first half of the presentation is basically the approach to a child with upper GI bleed. So I try to concise within a just revolving around the one case. I will discuss one case and then I will go step by step how to manage and what are the different causes. So upper GI bleed, I have already said the bleeding from the ligament of trees proximal to the ligament of trees. It's almost half of the all children with GI bleed. Almost 1/4 of the patient require ICU admission, and cause is usually identified in the small percentage of the children. It remains variety from mild to severe. I will discuss in the later slide how to assess the severity, and it can be overt or occult. We will discuss only the overt causes. So these are the age-wise etiology profiles. So there's a long list, but I tried some common causes. In neonates, swallowed maternal blood from a cracked nipple, or sometimes the neonatal enterocolitis. That NEC can be the one of the presentation where the blood can be lost from the lower GI tract or sometimes from the second is the most important hemorrhagic disease of newborn, and gastritis or stress ulcer when a child remain admitted in a nursery, and there's a lot of the sepsis and other things, then gastritis or stress ulcer can be the cause. But nowadays it is quite less common because of the prophylactic PPI therapy. Esophagitis, sometime in an immunocompromised patient, lot of candida infections or drugs, or sometime in a neuromuscular disorder, the patient can have a predisposition to the reflux diseases. So these are the cause. But cow milk protein allergy, sometimes the child can present with the only with the hematemesis. If the so cow milk protein allergy can is one of the common differential diagnosis in the well baby with hematemesis. Second thing is a congenital blood dyscrasia, like some platelet function defect. Platelet function defect in the form of Glanzmann's thromboasthenia, Bernard-Solier syndrome. These can be the presentation. Sometimes clue can be only the multiple side bleeding, sometimes the hematemesis along with the lower GI bleed. So multiple side bleed can be a pointer toward the some function defect. Vascular malformation. Infant, mostly the same, but vascular malformation is quite common. Sometimes the GI duplication cyst or Meckel scans, Meckel diverticular can be the cause. Swallowed blood in infant. Swallowed blood is different from the neonate. Swallowed blood here is because of the epistaxis, sometimes the oral lesions, teeth caries, and some. So they usually have a lesion in the nasal cavity or in the oral cavity. That can be the reason of a hematemesis. Now we will discuss in the older children. So in our country, older children, the portal hypertension remain the one of the most common cause of a GI bleed. In West, peptic ulcer disease is a common cause, but in our country, most common is the esophageal varices because of the portal hypertension, followed by the peptic ulcer, and rest are the quite less common. One important entity is a hemophilia. Hemophilia, there's a quinky cat. Whenever there's a jaundice and upper GI bleed and right upper quadrant pain, that can be the reason of the involvement of biliary system, like in the liver abscess. Sometimes trauma to the right upper abdomen. The patient can have a hematemesis and the blood is lost from a hepatic artery and it comes to the bile duct, and it child present with a hematemesis. So jaundice pain and uh, hematemesis can be a presentation of hemophilia. Thyroid lesion I have discussed. There's basically the lesser curvature. There's a free artery that can bleed. So basically, most common causes are the esophageal varices and peptic ulcer disease. So these are the two common causes. And one study from the India where the 75 patients were enrolled, and among 75 patients, 90% patients were due to the portal hypertension, either because of the extrahepatic portal venous obstruction or cirrhosis. Both are the common cause of the portal hypertensions. Rest, rarely the drug-induced erosions, ITP, or some rare causes. But most common causes in our Indian series is a portal hypertension in older children. So before just further going, so two questions need to be answered before just we are dealing with a hematemesis. First, are we dealing with a blood, real blood, or some other masquerader? So some food item like tomato, strawberry, pomegranate, they can give a red appearance in the blood, vomitus. Spinach and iron containing medication can give a malodontic stool. So sometimes these kits are available. Stool for occult blood, stool occult bedside kits are available. We can have because of the peroxidase in a hemoglobin. This test can turn the card blue. So this test can be in the difficult cases. We can identify the blood by doing this simple bedside test. Second thing is the bleeding GI tract. So I have already discussed. We have to evaluate for other cavities like nasal cavity, oral cavities, dental, and lungs. These three things should be keep in mind. These three cavity they have other sources of the hematemesis, so you have to need. And not last but not least, functional cause. Sometimes a lot of cases where the because of the some uh, other functional disorders, the child usually present with a wrong history of the blood in a vomitus. But we need to be very careful whether we are dealing with the blood or some other causes. So I will discuss one prototype case and then I will go with the upper GI bleed presentation. So 6-year-old boy presented to our institute with a painless hematemesis with clot and melena. This is the information. So three things. One is a hematemesis. Second point is a painless. Third thing is a clot and melena. Quite good information. But when we call any black stool as a melena, if it is a tarry black, if it is a false smelling, if we pour water and it comes the red, gives the red color, then we call as a melena, because there are a lot of causes of the black stool. So if these three histories available, then we call any stool as a melena. This is a well tolerated bleed, but so this is the important information. Whenever any child present with the hematemesis and with clot and melena, we need to know whether we are dealing with the portal hypertension or not. So there are two causes of the portal hypertension, as I have already discussed: EHPVO and chronic liver disease. So in chronic liver disease, sometimes decompensation in the form of ascites, encephalopathy, jaundice usually occur. So if the patient doesn't have any associated history of the jaundice, encephalopathy, or ascites, then we call this as a well tolerated bleed. It is nothing to do with the vitals, it is related with the liver decompensation. Other history in this child is that there is no past similar history of the bleed, but there's a history of the NSAID because the child recently had a fever and the cough. So for which the child received the mefenamic acid. No history of the umbilical catheterization. This is important history. In the past, we used to catheterize from the umbilical in the neonatal period, and the portal will get thrombosed, and that can be the reason of the EHPV in this subset of the patient. So ascites, jaundice, encephalopathy, we have to take the history of liver disease, and there's no family history of the bleed. Now in the examination, pulse rate 130 per minute, postural hypertension. Postural hypertension is basically when we have a normal BP and when we stand the patient for 3 minutes and there's a drop in 20 systolic blood pressure and 10 drop in diastolic blood pressure. We call the patient as the patient will qualify for the postural hypertension. So in this patient, tachycardia is there, postural hypertension is there, severe pallor is there, but no stigmata of the chronic liver disease, skin, caput and the hemangioma, no, splenomegaly is there, no ascites, all cavity normal, no encephalopathy. So what are the crux of the case? Hematemesis with clot, melena is there, tachycardia, postural hypertension, pallor, splenomegaly. So if we just compile all this information, there is a moderate to severe blood loss. So whenever there's a BP is maintained, but there's a feature of the postural hypertension, that means the blood is at 10 to 20% loss. And another information is from the what is the reason of the blood loss. So splenomegaly is there. So whenever there's a massive hematemesis along with the splenomegaly, the diagnosis is a portal hypertension until proved otherwise. So we have to keep in mind. So there's a two information. One is the bleed severity. Another is a cause is a portal hypertension. So we have to, next point is we have to decide what we need to do next. So another thing is we can identify the severity of the bleed by some scoring system. This is a Sheffield scoring system. Sheffield scoring system is a scoring for a UK based scoring system where you can apply this score and you can know the urgency of the intervention and you can know the severity of the blood loss. So this is like in the history taking, if there's a melena, large amount of the hematemesis, point is given as a 1 point each. If there's a tachycardia, prolonged capillary refill, then 1 point and 4 point, hemoglobin drop of 20 gram per deciliter 3, need for fluid bolus 3, need for blood transfusion 6, need for other blood product 4. So total scores 24. If cutoff is 8, if child is having that, if there's a cut 8 point is from these parameters, then there's a need of endoscopy and intervention. So in this patient, child calculated score is 10. So child qualify for a severe bleed and need of the urgent endoscopy and intervention. So this is a scoring we can apply. This is the only scoring in a pediatric for a GI bleed we can apply. Other scoring are Glasgow and other blackout for scoring, they are available for the adults thing. But if this scoring we can apply for the children. So another thing is the first thing is just sign and symptom we have discussed and evaluate the vital signs, perform baseline test, then lavage. So now our child is qualifying for the major and ongoing plate. So we need to resuscitate the child and we have to do the endoscopy within a 24-hour after the admissions. So 4 goals. Whenever we deal with any patient with the bleeding, we have to do the 4 things. First, restore and maintain the IV fluid. Then determine the source of site of the bleeding. then stop the GI bleeding by specific treatment, and then prevent the further bleed. So first step is we have to resuscitate. So immediately 2 lines were established. Vitamin K injection 300 microgram per kg IV was given. Octreotide, because this is a suspected case of portal hypertension, we started in advance a 1 microgram per kg IV stat, followed by the 1 microgram per kg per hour in this patient. Injection omeprazole was started as per the dose indicated because there's a history of the NSAID. Lastly, we have given in this patient the blood transfusion because the hemoglobin was low. In the later slide, I will show the investigations. So we maintain but most important thing, you should maintain the hemoglobin between 7 to 8 because higher level can be associated with the rebound portal hypertension and rebleed. Don't over transfuse the patient. Maintain the hemoglobin between 7 to 8. Insert the NG tube, monitor the urine output, vitals, and hematocrit. So this is the first step. We have to resuscitate by the volume. Second thing, so meanwhile investigation said was we have investigation hemoglobin 5.6, TLC 3800, platelet 90,000. So this show there's a hypersplenism and the blood loss was quite good. Liver function test coagulation profile was normal. We send the viral marker because these kind of the patient require repeated transfusion, so we need to have a baseline viral marker. Sometimes we always also do the anti-HBs titer if the vaccination status for HBs antigen is hepatitis B is not clear. So these are the basic tests we used to do. Then, as I have already discussed in the scoring system, that there is a need of urgency of the endoscopy. In 90% of the case, we can identify the bleeding site. Diagnostic accuracy is higher within the first 24 hours, but the patient should be stable before the endoscopy. And we can do the intervention also by the endoscopy. So in this patient, we did the endoscopy. Child showed the upper GI grade 4 into 3 column with RCS. RCS is a red color sign. Red color sign, which is indicative of higher chances of the bleeding. GOV1F1 is basically the gastric varices. GOV1 means the gastric varices along the lesser curvature. F1 is a grading. It's normally the low caliber varices. Mild PHG, portal hypertensive gastropathy. This is a endoscopic picture of the patient. What next? Meanwhile, we did the endoscopy, ultrasonography. Ultrasonography show the portal cavernoma, a lot of collateral around the portal splenic axis. Hepatic vein intact, liver normal, no nodularity and no ascites. So now final diagnosis is a EHPVO bleeder with hypersplenism, extrahepatic portal venous obstruction bleeder with hypersplenism. So what next? Now we have to do the endoscopy. Endoscopy management of esophageal varices. So the patient is bleeding, so we have to do the intervention. There's two modalities. One is a variceal band ligation. Second is a sclerotherapy. So difference between what to choose. So there are pros and cons of each modalities. Variceal band ligation, they have a rapid eradication. You can downgrade the varices very fast every 2 weekly. If you do, there are few sessions needed. But problem is that if you do only eradication with the variceal band ligation, there is a high chances of recurrence of the varices, high chances of the gastric varices, but less chances of the complication in the form of ulcer and the strictures. But another thing is a sclerotherapy. Sclerotherapy is when you do the sclerotherapy, there's a lower recurrence definitely, but there's a sorry, I have written the less complication, but the chances of the complication is high, like in the form of ulcerations and other things, and you need to inject something. So, but best modality is that you first downgrade the endoscopic varices, esophageal varices by the endoscopic band ligation with few sessions, and later on you just switch over to the sclerotherapy to prevent the recurrence. So this is a treatment of choice: endoscopic variceal band ligation followed by the sclerotherapy. So while doing the band ligation, you should keep in mind start from the GE junction and you should go spiral. Don't apply the whole band on the same level. Another thing is the sclerotherapy. You should inject the variceal intravaricial, not paravaricial. You should use 25 gauge needle. Start from the GE junction 2 to 3 centimeter, maximum 4 to 10 ml per session, depending upon the age of the child. So in this patient, child underwent first 3 sessions of EVL followed by the EST 2 to 4 weekly till eradication followed by the 6 to 12 monthly endoscopy. So we have done the endoscopy management. There are a few things, the gastric variceal bleeding. So while doing, I will not go into detail of variceal. So in this patient, we have done the 3 things. First, we have resuscitated the patient. Then we did the endoscopy, and then later on we just do the keep the patient on the endoscopic surveillance for to prevent the recurrence. So next, this is the first management. If this would have been the case with the peptic ulcer, how the treatment differ. So you most of the cases you don't know in the starting whether the patient is bleeding from the esophageal varices or from the ulcer bleed. But if there's a no splenomegaly, patient has a torrential blood, you can start the PPI infusion in the first step. And then next step is same, you have to do the endoscopy. So what you need to start in the if the you are suspecting the peptic ulcer disease, there are few options. Either you can start PPI infusion or twice daily IV therapy. So how to decide about the infusion or BD therapy, I will discuss in the next slide. So these are the standard dose of infusion: 80 milligram bolus followed by the 8 milligram per hour continuous infusion for 72 hours. The child is age of more than 12 year or more than 40 kg. If child is less than 12 years, then 1 milligram per kg IV bolus followed by the 0.1 milligram per hour in the children. Omeprazole, lansoprazole, esomeprazole, these are the FDA approved for the kids. So these are the intermittent and intravenous intermittent doses, and these are the oral. So in which patient we have to use the intravenous intermittent, in which patient we used to use the oral, or in last is a continuous infusion. So when we do the endoscopy, if you found any ulcer in the stomach, then we have to grade the uh, bleeding. And if it is a spurting, oozing, visible vessel, adherent clot, then we need to do the endoscopic therapy. So there are three modalities. When we do the endoscopy, if the child is having the bleeding ulcer, actively bleeding ulcer, then we have to do the endoscopic therapy. If child is having the flat spose or clean base, no endoscopy is needed, only oral PPI is sufficient. But if there's an adherent clot, then we can consider the endoscopic therapy along with the IV PPI infusion. So if you found any bleeding ulcer or adherent clot during the endoscopy, you need to do the endoscopic therapy along with the PPI infusion. So, so now the thing is clear in which patient you will use the IV PPI, if it is a bleeding or adherent clot, and if the flat base ulcer, only oral PPI without endoscopic therapy. So what endoscopic therapy? Injection, adrenaline we used to, and along with the thermal devices like heat pump and electrocoagulation. So combination of the injection with either contact thermal device or hemoclip we used to do. I will not go into detail. So now the step 4. So if there's a peptic ulcer, you will give the proton pump inhibitor after endoscopic therapy for 8 to 12 weeks. If there's a H. pylori, you have to eradicate that H. pylori also by taking the enteral biopsies, and you have to stop the insect. So these are the two most important cause of upper GI bleed, which I have discussed, and I have briefly discussed in a management of these two entities also. And most important thing at your level is to assess the severity of the bleed, whether the child is having the minor bleed or major bleed. So you can apply the Sheffield scoring system. And now the next part is with the gastroenterologist. They have to do the management, but in the few slides I have discussed about the management also, but I will not go into detail in the management. So next step is the approach to the child with lower GI bleed. So in the first, if I just concisely uh, conclude in the first part. So in the upper GI bleed, most common cause is a portal hypertension followed by the pyloric bleed. And at your level, you have to assess the severity of the bleed, and you should know the terminology. Approach to the child with lower GI bleed. So how to approach? So most common presentation of bleeding is a hematochezia. If bleed is from the lower part, means colonic or in the sigmoid colon, then the patient will present with the hematochezia, bright red color. If the patient is having the bleeding from the some middle part like jejunum or from the distal ileum, the patient can have a maroon blood change little bit, color of the color will change little bit, but definitely the hematochezia can be presentation from the middle bowel also. But if you are getting the maroon color, that most likely bleeding is from the distal small bowel. It can be occult and overt. What are the causes of the lower GI bleeds? So lower GI bleed is basically one is we have to rule out the food and drug. These are the same scenario like in upper GI bleed. You have to rule out the food and drug. These are the causes of the, these are common masquerader. So in the list, above 4-5 reasons are, these are the reason of milder bleed like infective colitis, juvenile rectal polyp, anal fissure, cow milk protein error. These are the common reasons of lower GI bleed. And these 4 reasons, they show they usually have a minor bleed. colitis, polyp, fissure, Cowmel protein. They usually present with a milder bleed, not large massive bleed. Lower down in the list, like ectopic gastric mucosa. Ectopic gastric mucosa means whenever there's a ectopic gastric mucosa at the other location, like in the small intestine or some area where the duplication cyst is there. They usually present with a massive GI bleed, painless massive GI bleed, maroon color, usually from the small bowel. Interception, vascular malformation, bleeding disorder, IBD, and henoxia in particular. These are the causes. They can have some telltale evidence of other symptoms also other than the GI bleed. I will discuss in the later slide. So these are the common causes. So we have to take that carefully. The history, bleed amount, pain is important. Whether the pain, while we deal with the lower GI bleed, pain is important. Whether the bleed is painless or painful, that can give us a clue about the etiology and its relationship with the stool. If the child is passing the blood immediately after the stool or drop by drop after stool, that means, and fresh blood, that means the bleeding is from the lower GI tract, from the rectum or sigmoid. Associated symptoms are important. If the patient is having the associated symptom of colitis, mucus, pain during defecations, along with the blood, then you are suspecting colitis, failure to thrive, or any perineal lesions. So this is a pointer of very early onset IBD. So if the child is having the blood per rectum along with these features, you should always suspect the very early onset IBD. If the child predominant symptom is a obstruction, intestinal obstruction, along with the red jelly blood-like stool, like excessive cry, abdominal distension, interception should be suspected. If constipation is there, you always should always examine the perineal area for a fissure. If child is having the some vascular lesion on the other part of the skin, then maybe might be having the child might be having the same lesion in the GI tract also. So vascular malformation. So these are the small pointer that can give us a clue about the etiology. If the child is having the skin allergy or recurrent wheeze and Cowmel protein allergy can be manifestation. Another most important is family history of bleeding disorder. Sometimes the GI bleeding can be due to the some bleeding disorder like platelet function defect. So detailed feeding history, examination in the form mainly the perineal and a rectal examination, vascular lesion over the other body part, along with the anthropometric parameters. Feeding history is always important. This is remain the one of the most common cause of bleeding per rectum in healthy child. CMPA, cow milk protein allergy, in small infant. So what should be the first investigation, primary investigation to differentiate? So CBC can give you a clue about the severity. CRP, fecal calprotectin, can give us a clue about the inflammation in the gut along with the bleeding. And albumin is basically a marker of the inflammation also, and also a marker of the volume loss. Stool routine and culture of colitis, you are suspecting bleeding time. This is an important test. Sometimes in emergency basis, we can do the bleeding time. Simple and important because sometimes we are clueless after the upper GI in the colonoscopy, and we have diagnosed few cases of the platelet function defect where there's nothing in the GI tract during the scopy, but bleeding time is a prolonged. So some platelet function defect can be so always whenever there's no clue bleeding time, we should do. Lastly, the three investigations. So three investigation that can differentiate most of the causes. One is a colonoscopy, another is a 99 M per technate scan for ectopic gastric mucosa I will discuss, and third is the imaging. So these are the three modality by which we can differentiate most of the causes of the GI bleed. So by doing which test should be performed first, which test next. So not all three tests you should do in each and every patient of GI bleed. That is basically depend upon the severity I will discuss. So I have categorized the lower GI bleed in the two category. One is that the child is stable, non-sick, no volume loss. Only the stable child presented to you with a GI bleed. So first thing is that if the child is having the small, painful stool, only coating the stool. That means the blood is coating the stool, not mixed with the stool. Child is passing hard stool, and there's a faulty diet. So we are suspecting basically we should first do the per rectum examination. That is the most important. You should look for a anal fissure. No need of any fancy investigation. This child is giving the enough clue about the constipation that can be the reason of the bleed per rectum. So per rectum examination should be done first in this kind of the patient whenever there is a small painful stool withholding postures and there's only the small volume. Next is if the child age is 1 to 2 year, child is passing small amount of blood after coating the stool, painless and soft form stool. So lot of fluid. Small amount, that means there is not severe bleed. Painless coating stool, that means that from the distal small bowel the blood is uh, losing, distal bowel is losing the blood, and soft form stool. So most importantly, we have to do the we should keep the first possibility is a rectal polyp, and we have to do the ileocolonoscopy. So two possibility can be there. One is a polyp, another is sometimes the vascular malformation can present the same presentation in the form of small painless blood. So there's a difference. So if the child is having a painful stool, small hard stool, small blood loss, then per rectum first for fissure. If the child is passing small painless stool, coating the stool, form soft form stool, then first investigation should be the ileocolonoscopy after per rectum examination. Third, third category is if child age is less than 1 year. Again, small painless stool, coating stool, that means from the distal bowel, and if there's a temporal correlation between the bovine milk. So you can do the plus minus gentle examination, but no need. So in this case, CMPA, cow milk protein allergy, you should suspect. Some always look for the association between the blood and there's a feed dietary history. If there's a good correlation, then you can do the you can keep the possibility of the CMPA. Two things. As per the guideline, elimination diet should be given if CMP is suspected, but we used to do the proctosigmoidoscopy. If there's a proctosigmoidoscopy, there's a aphthous ulcer, then we keep the diagnosis of the cow milk protein allergy. Sometimes we, in this category also, we usually get the vascular malformation also. So last, if you have acute loose stools with mucus and tenesmus, so this is a classical infective colitis. This is the most common cause. So depending upon the presentations, you can categorize the bleed uh, in a stable child in a 4 categories: infective colitis, polyp, fissure, and vascular malformation. These are the common causes of GI bleed in a stable child. Next, so this child, 6-month boy, presented with a painless small fresh blood without clot for 4 weeks, age 6 month, exclusively breastfed till 4 months, followed by the breastfeed plus bovine milk. So there's a temporal correlation. Immediately after the bovine milk, the child started having the bleed. All investigations, all thing is not, no failure to thrive, everything is normal. So proctostigmoid we did, there was a aphthous ulcer in the rectum, histopathology showed the eosinophil, and child responded to the bovine milk elimination. So this is the classical case of cow milk protein allergy. So now we discuss the next part. Lower GI bleed if the child is sick or hemodynamically unstable. So what are the cause in this category? First, we have to look whether the child is having some sign of the obstruction or not in the form of acute abdomen. Pain is there, obstruction is there. Then first thing we have to do the radio imaging. First we do the X-ray abdominal rect for look for the intestinal obstruction, followed by the CT. If there's sometimes the interception is there, so surgical re-exploration. So it's important. So in sick category, you have to take the other consideration of other symptoms also. So only GI bleed, painless bleed, massive, child is having the hemoglobin of 5, 4. So first test should be the Meckel scan. So Meckel scan, so you have possibilities of duplication cyst or Meckel diverticulum. So in case of the massive GI bleed, no other sign of acute abdomen or obstruction, then you have to first investigation should be the pertechnetic scan. If it is a positive, then there are two possibilities: Meckel diverticulum and alimentary tract duplication. So another treatment of choice is a surgical exploration. If it is a negative, then you have to do the upper GI and colonoscopy and CT angiography to look for the other cause. Sometime in Meckel diverticulum also you will get a scan is you can get a negative scan, and in highly suspected cases again if the thing is negative then surgical exploration is needed. Last presentation is a colitis like presentation, like IBD like presentation. If the child is having some symptoms of mucus is there, significant failure to thrive, some perianal fistula is there in small child, anemia, and the inflammatory marker are positive. So then first, if the history is acute, then you have to treat for the infective colitis. So if the colitis history is prolonged, if it's a 3 months, 4 months significant failure to thrive, then you have to do, you will not keep the infective colitis as a diagnosis. In chronic colitis, you have to do the endoscopy. Endoscopy can be the very early onset IBD, small child. In big child, that can be the normally standard IBD. And sometime Juvenile polyposis coli can give you a colitis-like presentation. So it is not like the polyp always present with only the GI bleed. It can have a colitis-like presentation if there's a lot of polyp in a small bowel. So in this category, you have to do the uh, uh, endoscopy. If all things are negative, like scan is negative, radio imaging nothing, all endoscopies are also negative, then you should always keep the possibility of the bleeding disorder. So I just show you another example. So this 3.5-year-old boy presented with a painless massive maroon rectal bleed with clot. So painless maroon color, that means the blood is oozing from a middle bowel. So as per our protocol chart, only the GI bleed. Child is sick because the massive blood loss is. So we did the first investigation. After transfusion, we do the scans. So fortunately, the scan came positive in this child, and child underwent myocardial diverticulum, and child was well after that. Next thing is a hematemesis with clot. So one thing is in this patient hematemesis with clot. Another thing is the painless fresh bleed per rectum along with the melena and past history of the nasal bleed. So clue from this part, there's a lot of different segregate areas oozing. One is from the upper GI tract because the child was having hematemesis with clot, melena was there, and also fresh bleed per rectum. That means another area is from the lower rectum and history of the nasal bleed. So three different cavity were bleeding. So that always keep in mind whenever this kind of the picture comes, then you always suspect, are we dealing with some systemic disorder? It is not some local disorder where the only the one side is bleeding. It's bleeding from the multiple sides. So in this patient, we keep the bleeding disorder as a first possibility, and we did the investigation. Hemoglobin was 7, platelet was normal, everything was normal. There's no specific changes in the upper GI and CT. Upper GI showed multiple superficial erosion in the fundus and duodenum. CT showed diffuse mucosal thickening of the stomach and small bowel. Bleeding time we did in this patient was prolonged, and platelet was transfused and bleeding was stopped. So clue from the part case, multiple site of bleeding, non-specific change in upper GI tract, bleeding time prolonged, rest all workup negative. Keep the possibility of the platelet function defect in this patient. And this child turned out to be a Glanzmann thrombocythemia. So this is important. When you have a no clue from the upper GI colonoscopy and CT is normal, multiple site, bleeding time prolonged, you always keep the possibility of platelet. It is not quite less common. It's quite common. If you are having the hemato-oncology department in your institute, then these are mostly you will encounter this kind of the patient. So recurrent, another case, 2-year-old boy. Now this is a third presentation of severe bleed, recurrent episode of colitis, and this child also had a
Dr.
history of the
Vikas, your
pneumonia.
voice is not audible.
Okay, so now am I audible, Dr. Shyam?
Audible.
Hello.
Audible,
Hello.
sir. Audible.
Dr. Vikas, you are audible.
Continue.
Hello.
Dr. Vikas, you are
So-
audible. Can you hear us?
Yes, you are
Yes,
audible.
please continue.
So another presentation. This child presented with a recurrent episode of colitis and history of pneumonia on and off from the last 7 years. There's a history of the weight loss also and recurrent itchy skin lesion. So multi-system involvement. There's a colitis, pneumonia, and there's a scalp abscess that were drained, and there's a consanguinity and SIP death. So we kept the possibility of the immunodeficiency and very early onset IBC because there's a multiple marker in the history along with the bleeding per rectum. You will get, so this is a case where you get now in this patient pallor was there, and a sarca was there, clubbing, oral thrush, angular cheilitis, and telltale evidence of the pneumonia. So in this patient, we did the workup in the form of upper GI colonoscopy. Colonoscopy show the pancolitis-like picture, deep ulcerations, skip lesions, friability, IC wall normal, but ileum show ulceration. TB workup was negative, MAN2 negative, and HIV immunoglobulin sepsis workup negative. Biopsy showed there's only the chronic active colitis. Immunostaining for CMV was negative. So we kept the possibility of the very early onset IBD. This child was started on the steroid because they denied for infliximab biologicals. So because it's a penetrating disease, but we started this patient on a steroid azathioprine, and fluconazole also started. This child improved after the immunosuppression, the ESR, albumin, hemoglobin, CRP all get normalized, and the child started gaining weight. But again, this we optimize the immunosuppression, And initially child improvement, there are again the recurrence of the loose stools and the weight loss after a few months. Then we did the clinical exome sequencing. There is a caramel 2 mutation positive, immunodeficiency 58. So child planned for the hematopoietic stem cell transplantation, but child's come because of the severe sepsis. So this is a like a different presentation. So we discussed 3 presentation. One, only GI bleed, only lower GI bleed, then you should keep the possibility of the ectopic gastric mucosa like buccal diverticulum or duplication cyst. If the intestinal obstruction, then interception. If colitis like presentation, then immunodeficiency or very early onset IBD. These are the 3 main presentation of the lower GI bleed. Another thing is a vascular rear cause. They usually present with a painless GI bleed, lower GI bleed, and mostly 2 common reason in a children is one is a angiodysplasia, another is a blue rubber never syndrome. In blue never syndrome, you will get a lesion in somewhere else also in the skin. I have discussed coagulopathy and platelet disorder. So this is our institute experience of lower GI bleed in toddler, and colitis most common, followed by the juvenile rectal polyp and anal fissure. Rarely we get the cow milk protein allergy, and rarely Meckel diverticulum, duplication cyst, infantile IBD, and juvenile polyposis coli. These are the presentations. Another experience from the SGPGA where the Meckel diverticulum is a surgical experience. This is a surgical experience where the Meckel alimentary tract duplication is the most common surgical cause of bleeding, followed by the polyposis coli and lymphovenous and malformation. So I've discussed, so most important, last I will conclude the session with this last 2 slides. So stepwise approach. First, you have to assess the severity, mild, moderate, severe, but you can apply the Sheffield scoring system. You can identify, you can assess for the need of the urgency of the scopy. You should identify the source. History and examination can give us you a clue, lot of clue. Basic investigations is sufficient in the initial stage, and later on between the imaging, endoscopy, a scan, you can, depending upon the base of the presentation, we can choose one investigation. So key takeaway message is that anal fissure is most common cause in toddler. Always assess for red flag sign, structure evaluation, avoid the unnecessary test. Bleeding disorder should always be differential. Thank you.
Wonderful presentation, Dr. Vikas.
Yes, thank you, ma'am.
Few things I would like to add that as we know that as Dr. Vikas has elaborated, that GI bleed in children is not a diagnosis. It's just a clinical sign. And for diagnosis, most of the times we need to scope the patient, either upper GI endoscopy, lower, or both. At times we need to do both upper and lower GI endoscopy. And in my practice, I've seen that there is some apprehension while subjecting the patient to endoscopy in the minds of general practitioners. So should be clear that endoscopy is a very safe procedure. And in most of the cases, if we don't scope the child, then maybe we can miss the diagnosis and it will be difficult. They can have rebleed and further follow-up will be difficult. Secondly, as Dr. Vikas has elaborated, that surgical cause of lower GI bleed is very less as compared to the medical causes. Like you can have like Meckel's diverticulum, or in which surgery is required. But in most of the cases, it is the medical cause that is of GI bleed is there, and it is not the domain of surgeon, because most of the times lower GI bleed is referred to surgeon first, and then they come to pediatric gastroenterologist. So even in lower GI bleed, as Dr. Meena has tabulated, that in most of the cases, we will need endoscopy. And it should be very clear that endoscopy is a safe procedure. So if the patient is primed beforehand that endoscopy will be required, their readiness for endoscopy becomes better. Yeah.
Thank you, Dr. Ranjit. Mainly, most common cause in upper GI bleed, if bleed is severe, is a variceal bleed. If lower GI bleed, if the most of the common cause of the severe lower GI bleed is usually the ectopic gastric mucosa or
Right.
some vascular. But most of the benign causes you can deal with the gastroenterologist level. Like if the bleed is small in the lower GI tract, the most common causes are anal fissure, polyp, and these are the some causes that can be handled. But severe bleed definitely in upper GI, the gastroenterologist, because the variceal bleed need ligations and the EVL, EST, other things. In lower GI bleed, if severe bleed, the most common cause in surgical series, they are the duplication cyst and the Meckel scan, Meckel
Right.
diabetes.
Also, in variceal bleeding, the patient will need several sittings for band ligation and sclerotherapy. One sitting is not enough for variceal bleed treatment.
So it is not like a one-time procedure. The child
Yes,
need to undergo multiple session of endoscopic therapy in upper GI bleed for variceal band, like for variceal bleeding. And even after eradication, the child should need to be kept in surveillance for a after 6 monthly or 1 yearly after the eradications. One
absolutely.
important thing at the pediatrician level, if the child is having the upper GI bleed, massive GI bleed, and splenomegaly is there. So most common cause that we are dealing with the EHPVO. So you can start octreotide, you can maintain the hemoglobin between 7 to 8, and you can keep and then you can refer. So
Right.
at initial resuscitation level, the hemoglobin should be maintained, octreotide should be started, one vitamin K dose is enough, and that's enough. If the child doesn't have any encephalopathy, jaundice, well tolerated bleed, but massive bleed, don't be panic. Start octreotide. Give if the splenomegaly is not there, even if you're suspecting massive GI bleed, portal hypertension, even in the absence, you can start octreotide, and we can stop the octreotide once the endoscopy was done and there's a usually done and there is a no there is yes, then we can stop the octreotide. But you can start octreotide during that period if the bleed is massive from the upper GI.
Right.
Thank you, Dr.
Uh,
Vikas, for the wonderful talk. And before going the more discussion, I would like to take some questions from our audience. One of the audience asking the treatment part, as you said, omeprazole dose, as we already covered in our discussion. One of the audience says how the assess the drop of the hemoglobin more than 2 gram per deciliter at the admission.
So
So I just want to clarify from the
So,
your side,
so
what
this
are the modalities available for the assess the ongoing blood loss at the bedside as well as laboratory side?
so so you're right. Sometimes we don't know the baseline information about the hemoglobin before the bleed. So this parameter in this even in this our in our in our case also we cannot apply because drop in hemoglobin by 2 week you cannot apply if you don't know the first hemoglobin. But there are a lot of other parameters you can apply. That's why the scoring is important because out of 24 hours you need only 8. You can skip few parameters you don't know. Even if you don't have a if you, even you don't have a hemoglobin, you can apply the other parameters you can see in the slides, and you can easily get the score of 10. So forget about the drop of 20 drop of more than 2 gram. You can apply other like if the need of bolus, need of blood transfusion at the current level, if the hemoglobin is less than 8, then you can easily reach this score.
So in the short, if we are not have the idea about such a type of the scoring, then we can use our basic sense.
Other
Like
ways.
the bedside, we can closely monitor the heart rate of the child. If the changing in the heart rate, dropping or rising, that might be indicate that some of the going the wrong. Other basic things like the blood pressure, urine output, and by the laboratory basic parameter, we can see the trend of the hematocrit fall. These are
Definitely.
the basic things, and that on the basis of that, we can take the help.
Mhm.
Other audience asking the what are the role of the CT in the GI bleed, and what about the RBC scans. So, would you like to take the some of the grading, or what are the limitations or advantage, or in the short?
So scanning the scans basically they are important whenever you don't have an etiology in a endoscopy. If you have a variceal bleeding in the upper GI tract, then there's no use of if you don't have any etiology in upper GI tract, like if you don't upper GI is normal, colonoscopy is normal, and you don't have any clue about the loss of site where the blood is oozing. In that case, you can have a scan like you have a three modality in that case. One is a scan, nuclear scan. Another is a CT angiography. There are two things. Scan are of two type. One is a per technique sulfur scan. Another is a per technique
It's
RBC scan.
it's
So,
okay, sir. It's okay. Just we want to clarify because our audience is a pediatrician.
so scan is
So
not a first investigation in patient if you have a obvious lesion in a
So,
upper GI tract.
if that the clear cut message, if you are sure that the source of the bleeding is the GI bleeding, it's better to start the baseline treatment as stabilization of the patient, then hand out to pediatric gastroenterologist before doing the too much invasive investigation or like the CT or RBC scan. As you already told, in the obscure bleed, definitely scan, RBC scan or CT scan might be contribute, but the upfront try to avoid the lot of the radiation by the CT scan before
Definitely,
taking in the final decision.
definitely.
What are the other medical or pharmacological options, especially if the suspect we are the suspecting the varicose bleed if the octreotide is not available? Because in the mostly in the peripheral or secondary level, the octreotide might be not available.
So you can give the vasopressin. You can give vasopressin is easily available in most of the emergency. You can start with the vasopressin. The dose actually we are not using, but octreotide is easily available. You should keep this as a one of the emergency drug. But in emergency cases, you can start the vasopressin also.
So definitely other alternative drugs other than octreotide, we can use the somatostatin, vasopressin, whatever drug is available. You should be start before refer to patient to higher center. Would you like to give the comments about the one of the common sentence we use as a gastroenterologist, pre-referral treatment in the GI bleeder, especially in the upper GI bleeder? Because, so would you like to comment any?
So one thing is that as I already discussed, the bleed is severe in upper GI bleed. Then you should three things you should do. First, you should have to maintain the hemoglobin. If the bleed child is having the 5 hemoglobin, 4 hemoglobin, then you maintain between 7 to 8. You give one dose of vitamin K. You start one dose of the proton pump inhibitor like omeprazole or lansoprazole. You give the start dose of octreotide and start the infusion, and then you can refer easily.
Yes, sir.
So
That
this
the
is the first.
triple triple drug therapy is a very life saving drugs, especially those who are the working in the periphery or private small setup. Before refer to patient, please advise the three important medicines: vitamin K, preferably IV. We are not aware about the INR status to avoid the IM, and pantoprazole as well as octreotide. In your first case, you said the child have the massive GI bleed with splenomegaly with pancytopenia. Always think about the variceal bleed, because I'm also working in the tertiary care hospital. My 90% resident make the first differential diagnosis as a leukemia rather than variceal bleed, because CBC most of the time said as a pancytopenia. So they made the first differential diagnosis as a leukemia. Even many times I got the referral patient after bone marrow aspiration or biopsy. Would you like to give any comments in the short?
No, definitely you are right, Dr. Sham. Whenever there's a massive GI bleed with splenomegaly, the first difference should be the portal hypertension rather than the leukemia and the lymphoma. And leukopenia and thrombocytopenia in this case is usually the hypersplenism, not a bone marrow involvement.
So definitely here killer cut message that pancytopenia contributed by the overfunctioning of the spleen rather than bone marrow involvement. If you go through the peripheral smear, the reticulocyte count is absolutely normal in the such a cases rather than bone marrow cases involvement.
So if you another thing is if you really want to just do some investigation, extra investigation other than the baseline investigation in these kind of the patient, you should do the ultrasound Doppler, hepatobiliary Doppler immediately.
Exactly.
And immediately you will get the result. Like if you have a portal cavernoma, then most likely diagnosis is clear. You are not dealing with the lymphoma leukemia.
Here, clear cut message rather than taking the call for the CT in the massive GI bleed, first take the ultrasound Doppler. That is might be contribute for the further treatment to decide the continuity of the octreotide.
So
About the lower GI bleed, you said the child have the might be other various etiology like the cow milk protein or like the inflammatory bowel disease. Any more simpler approach about the in the keywords for the our pediatrician?
So first, most important is the cow milk protein allergy. The most of the kids they present in the first 2 year of life. So first is the age. So if the child is have small child, if the small child is less than, especially less than 1 year, small infant, if there's a temporal correlation between the bovine milk and the onset of the bleeding, one is a temporal correlation. Another thing is a small kid, another pointer, and child is usually remains stable. This is a category where the child usually they have only a small amount bleed per rectum. Mother will tell you the मेरे जो बच्चा है उसके जो है डायपर में रेड कलर का ब्लड आता है. So this small healthy kid, early infancy, temporal correlation, you should always suspect the always the CMPA. So this is
Okay.
the clue.
Okay. Thank you, sir. Dr. Rimjim, final remark from your side about our audience related to GI plate.
Yeah. So, GI bleed is very commonly seen, and it is very important that we find the etiology of GI bleed, and for that we need a referral to, most of the time, referral to a pediatric gastroenterologist. Endoscopy is not a difficult procedure or unsafe procedure. So, if a patient is required to have endoscopy, then they should be subjected to endoscopy. And as Dr. Vikas rightly said, that pre-referral treatment should be done. And most of the times, like upper GI bleed is a varicose bleeding, and it is self-limiting bleed. So even if you don't have vasopressin, somatostatin, or octreotide available, even if you transfuse the child and refer the child quickly, that will be sufficient. So don't worry that if octreotide is not available. So don't panic that octreotide is not available. In most of the cases, it will bleeding will stop on its own because it's a game of pressure. And if you can refer quickly, then further management can be done. Yeah.
Thank you. Final before closing the session, final remark from my side. Any upper GI bleed, that child have the massive significant amount of the bleed, because child we taking the indirect history from the parents, we can't rely on the volume of the blood loss. So any child hemodynamically unstable or historical or pictorial have the significant GI bleed in the form of coffee color vomiting or black terry color stool, always consider as a variceal bleed until unless proven. Start pre-referral or first line treatment like the emergency treatment as per as ETAT protocol. Try to stabilize the child. Start the triple therapy including vitamin K, preferably IV, pantoprazole along with octreotide. Then send the CBC to confirm the document the baseline hematocrit, along with very closely monitor the heart rate. Because if you not have the laboratory facilities, heart rate might be more useful to further decide the dose of the octreotide. Then get the call as early as possible for the ultrasound Doppler. If Doppler says the child have the variceal, portal vein thrombosis, or replacement of portal vein by the collaterals, then continue the octreotide. If the Doppler is not suggestive for the variceal, then stop the octreotide, continue pantoprazole, and involve the gastroenterologist as early as possible. That is very clear-cut message for the upper GI variceal bleed. Please don't bother about the spleen present, yes or no. Sometime in the massive GI bleed, spleen might be shrunken and transiently splenomegaly might be disappear. So don't blindly rely on that, but you should use your common sense. That is a basic clear-cut message of audience for the upper GI bleed. Other thing, because we are dealing many cases and the fallacious meninges as a fallacious GI bleed. So history is very important thing. Always don't hurry to take the call for the upper GI endoscopy. Detail history, detail pictures, or you can documentation, that is very useful. In the lower GI bleed, very simple approach. If the child you are dealing such a massive GI bleed that is painless, child belong to teenage age group, always think that likely bleed due to the Mickels. The child should be admit, send for the Mickels scan, transfuse the bleed, maintain the hematocrit as much as possible around 8 to 10. That is the best way. If the child have the same age group like the teenage but painful bleeding, then you should consider the duplication cyst, take the ultrasound for the SMA SMV relation, or maybe for the duplication cyst that might be contribute. Similarly, if the child have the older age group or child have the intermittent mild bleed, sometime with the stool, sometime at the end of the defecation, may or maybe have the parectal mass in the history or even in the PR may be normal, then because here the painless intermittent bleed, you must be think for the rectal polyp, and better to refer the child for the pediatric gastroenterologist rather than surgeon to for the definitive therapy. Other, if the child have the painful intermittent mild bleed with the stool or after stool, then might be that bleed due to the constipation associated fissure, hemorrhoids, or maybe long standing constipation cause the solitary rectal ulcer. In that situation, better to hand out the child to pediatric gastroenterologist along with adequate dose of the constipation as we discussed in the previous session with the Dr. Sugato Meto. Thank you, Dr. Vikas. Thank you, Dr. Rimjim, for the valuable input. I'm sure our audience will get the benefit. Please, my request to our participant, what you learn from this platform, use for your patient that might be useful. Over to IIP Delhi office bearer. This.
Thank you, Dr. Meena, and such a wonderful lucid session by Dr. Vikas. And I think it's very, very important session, and you are percolating the knowledge to the delegates and new youngsters, young PGs, postgrad students also. Now over to Dr. Ajay Gupta sir for remarks.
Thank you, Dr. Dinesh. We are really thankful to Dr. Vikas and Dr. Imjim for a wonderful session. It was really simplified the things in a great way. Uh, Most important is to manage the patient. You always look for signs of shock. If the child is sick or something, do the first management of ABC. Because if there was excessive bleeding and child is in shock, always manage the shock first and always do a local physical examination. A simple lesion in the mouth or anal fissure can solve your problems to a great extent because most of the cases of lower GI bleed may be associated with fissure or some lesion in the mouth. Sometimes even the epistaxis, child may swallow the blood
Definitely.
and may vomit it out. So always look for features suggestive of all these things and going for invasive investigation should be the last. Always do basic investigation first, and a careful clinical examination is most important. Thank you. Thank you. And I request all the delegates to please join next week also. Over to Dr. Dinesh.
Yeah, now, one second, 1 second. I request, first of all, I welcome Dr. Ravindra Kumar, our treasurer come secretary elect also, and he has just joined. And I request him to put vote of thanks on the behalf of IP Delhi, sir. Please, sir.
Thank you, IP Delhi, Dr. Ajay, Dr. Dinesh, and thank you, Dr. Meena. Another episode of a very wonderful, GI session. Thank you all of my faculty, Dr. Rimhim, Dr. Shalja. Nice to see you, Vikas, after a long time.
Thank you,
I,
sir.
I sincerely request you to please do join your IP North Delhi CMEs also. You are missing. I'm making you absent over there.
Thank
I'm waiting for
thank
you
you,
there.
sir.
Today's session is very, very important. That is true. I mean, upper GI bleeding, because I'm from a government setup, I do see lots of cases. And what Dr. Meena has raised the point, pancytopenia with splenomegaly with upper GI bleeding. Usually, yes, it is the first time we think of leukemia. You know, Dr. Meena, because when there is a pancytopenia, our PGs always think of, maybe some sort of leukemia, and we should not miss it because it's a very dangerous diagnosis, disease and maybe sometimes maybe lethal. And thank you, Dr. Vikas, for
Thank
pointing
you,
out
sir.
a possible Doppler USG that will make a difference. However, many times, a patient coming in the wee hours of the day, and especially in government institutes, Doppler is not available. If it is, maybe at night or in the evening. But yes, I mean, that's a very important message that we should speak in portal hypertension because I still remember my days when there is a splenomegaly with upper GI bleeding, the
Definitely, sir.
diagnosis is just portal
Definitely.
hypertension. So thank you all for raising and giving a very important, these are all very clinical cues which are very helpful. And I hope all of our delegates will be, must be delighted to know all of these. These are the tips. I think we should make a, after I'll request Dr. Meena, just make a flag to our delegates also. But these are the certain tips, from each session, 5 or 6, these tips, which are very, very important. So thank you all. Thank you all.
Thank you.
Thank you, Dr. Rindram. Thank you, Dr. Vikas. Thank you.
Thank you. Thank you, sir.
Thank you. Thank you, everybody.
Bye bye.
Bye, bye, bye.